Okay, so I let my cat come in the room with me, so hopefully you won't hear any meowing. And I am going to start with the third part to regulation for your patho lecture. In this one, we are going to focus on the liver, in particular cirrhosis as the exemplar. It's chapter 30 from your patho book, but I did use a mix of the patho book and then the chapter in the med-surg book. Here is this lovely concept map, and we are going to move right along from that. All right, so a brief bit about the normal liver. It is the largest solid organ in the body, located in the right upper quadrant of the abdomen. It weighs between 1,200 and 1,500 grams, and the liver is divided into 4 lobes. They call each one of them a lobule, and it is the functional unit of the liver. Hepatocytes are the cells in the liver. And then another thing you need to know is Kupffer cells. Kupffer cells are phagocytes that destroy bacteria and foreign material in the blood. The blood gets to the liver from 2 different ways, the portal vein and the hepatic artery. So 80% of the blood supply to the liver is from the portal vein. It is the vein that drains the GI tract, so it's really rich in nutrients, but because it's a vein, it does not have oxygen. The hepatic artery supplies the other 20% of the blood to the liver, and this one is rich in oxygen. Venous drainage occurs from the hepatic vein, and it empties into the inferior vena cava next to the, or near the diaphragm. This next slide is just a picture of what it looks like in one of the liver lobules. All right, more on the liver, we can talk about the common bile duct. That is where the hepatic duct and the cystic duct is from the gallbladder, so it's where the hepatic and the cystic ducts both join, and then it empties bile into the small intestine at the duodenum. The flow of this bile entering is controlled by the sphincter of Oddi. The liver has several different functions. It's a pretty important organ. Right? It is used for detoxification, metabolism of medication, ammonia conversion, protein, glucose, and fat metabolism, bile formation, bilirubin excretion, coagulation, storage, and a ton more. If you want to know everything the liver does, it's on page 727 in your patho book. But it's important to know the function of the liver because then you can figure out what the symptoms would be of a dysfunctional liver. Right? So if the liver is responsible for metabolism of medications, and if the liver is not working, those medications are going to stay in the body and become toxic. Right? The liver is responsible for converting ammonia, and if it's not functioning, that ammonia is going to build up and stay in the blood, and that's where you're going to see the hepatic encephalopathy. Right? So if you go through these and you think, well, what would happen if the normal liver didn't do what it was supposed to, then you'll know the signs and symptoms of cirrhosis. Here is a list of all of the different diagnostic evaluations that may be done for the function of the liver. What's important to know, though, is that more than 70% of the liver may actually be damaged before tests even show it's abnormal. All right. And another thing I want you to keep in mind is that there's other disorders that can affect some of these tests. So abnormal labs are not a definitive diagnosis. It just helps along with symptoms and ruling out other things to get to the diagnosis of liver dysfunction. All right, so the first one up is your liver function test. They are, there's a couple serum enzymes. They're called your serum aminotransferases. They're a pretty sensitive indicator of injury to the liver cells and are very good at detecting acute liver disorders. So the first one you have is ALT. Your ALT increases primarily in liver disorders. Your AST increases with liver, bone, heart, and kidney issues. And then your GGT is associated with cholestasis, which is that reduced or stopped bile flow, or alcoholic liver disease. But these three, the ALT, the AST, and the GGT, are the typical enzymes that they do in a liver function test. It's important that you remember these, hint, hint. And then there's also alkaline phosphatase and lactic dehydrogenase. Some other blood tests that might be ordered is looking at albumin levels, the bilirubin, ammonia, clotting factors, and then lipids. They may also do a liver biopsy to look for different things such as cancer, or they might do an ultrasound, CT, MRI, or other imaging to take a look at the liver's size and if there's any damage present. Hepatic dysfunction results from damage to the liver's parenchymal cells. And these cells respond to the damage by replacing glycogen with lipids. This replacement is going to produce fatty infiltration. And then on top of that, the cells can regenerate, but only if the liver damage isn't too toxic. So if you have severe liver damage or continuous damage, then it's hard for those cells to regenerate, and you've got the sclerosis forming, the fibers, and all of the stuff that goes into the inflammatory response, plus the liver starts to shrink. So there's two different things. The damage can be directly or indirectly. Directly would be from primary liver disease, or if it's indirect dysfunction, it comes from obstruction of the bile flow, or if it's a hepatic circulation issue. Liver dysfunction can be acute or chronic being way more common, and can result from a couple different things. So things like virus, obesity, alcohol or other toxins, tumors, and nutritional deficiencies. Chronic liver disease is the 12th leading cause of death in the U.S., and at least 40% of those with chronic liver disease were associated with alcohol use. The rate of hepatic dysfunction is twice as high for men, and then it's more common in Asian and African countries than it is in Europe and U.S. Here's a list of common manifestations of liver disease in general. They might have vague abdominal pain or right upper quadrant pain, indigestion. They might have an enlarged liver, jaundice, edema, and then some different nutritional deficiencies. And the reason they have those, again, is the liver is partly responsible for glucose, fat, and protein metabolism. And if the liver is damaged, then they can't metabolize those or other vitamins. So they also have impaired absorption of your fat-soluble vitamins. If you remember, that's A, D, E, and K, and then folic acid. And then they'll have impaired absorption of dietary fat, so sometimes you will see fatty stool. And the reason behind that is there's not enough of the bile being secreted into the intestines to help break down the fat. And then there's decreased production of your clotting factors, and that is because the liver has the inability to use vitamin K to make prothrombin. So a little more on jaundice. Jaundice happens because it's the decreased ability of liver cells to conjugate and excrete bilirubin. Bilirubin is formed from aging red blood cells, and usually only a small amount of bilirubin is found in the blood because the liver is able to excrete it. So if someone has jaundice, it's this yellowish discoloration of the skin and deep tissue from abnormally high levels of bilirubin in the blood. The normal serum bilirubin level is 0.1 to 1.2. You can classify jaundice as hemolytic, hepatocellular, or obstructive. Hemolytic jaundice occurs when the red blood cells are destroyed at a rate that is too much for the liver's ability to remove it. So the liver function is normal. The problem is just there's an abnormal amount of bilirubin being produced. With hepatocellular, it's because the liver cells are not able to clear normal amounts of bilirubin in the blood, right? So with hemolytic, it's a bilirubin issue. Hepatocellular, it's a liver issue. And then obstructive is occlusion of the bile duct. So things like gallstones, tumors, or having an enlarged liver or gallbladder can obstruct that bile duct. Findings of jaundice, you'll see yellowing of the sclera and skin. You'll also see yellowing of the hard palate, and I'll show you a picture in a second. They'll have itching, a lack of appetite, nausea, and weight loss, malaise, fatigue, weakness, and then you'll see elevated AST and ALT levels. Those are your liver function tests. And then if the cause is infectious in nature, you might see headache, fever, and chills. So here is a picture of jaundice, and these are pretty easy to tell. The skin's yellow, and then the eyes are yellow as well. But sometimes in darker skinned patients, it's really hard to pick up on jaundice because they might have some yellow undertones in their skin. So that is why the best way to tell jaundice in someone of dark skin, an African American, would be the hard palate. And this is what it would look like. So here you can see that there is the yellowing in that hard palate. Complications of liver disease develop because of that liver impairment or failure. Again, more than 80 to 90% of hepatic function is compromised for these overt symptoms to start appearing. The most common complication of liver disease is portal hypertension. Right? Portal hypertension is occurring because of those structural changes that happen in the liver. And then the changes, or the enlargement of the liver, basically, is causing compression and then destruction of the hepatic and portal veins. Okay? This is going to lead to hypertension. And then having this portal hypertension is also associated with splenomegaly, the esophageal varices, ascites, hepatic encephalopathy, hyponatremia, and hepatic pleural effusions. Another common complication of liver disease is ascites. It is a late-stage manifestation of cirrhosis, and again, usually goes hand in hand with portal hypertension. It is the accumulation of serous fluid in the peritoneal or abdominal cavity. This fluid is rich in albumin, and I'll tell you why in a second, and then what you will see is weight and abdominal distension. So your patients with ascites, it's important to measure their abdominal girth as well as their daily weights. All right, so ascites usually becomes clinically evident when there's at least 500 mLs of fluid that have accumulated. And then the amount can be so great, I mean, several liters. I've seen patients where they've drained just bottles and bottles of fluid. But when they have that fluid in there, it's not only going to distend to the abdomen, but it interferes with breathing. Some contributing factors is the increased hydrostatic pressure from the portal vein hypertension. And then there's salt and water retention by the kidneys. And the third one is that decreased colloidal osmotic pressure. And the reason behind this is because of impaired synthesis of albumin by the liver. Right, so oncotic pressure is that pressure that's going to pull water into the circulatory system. And once it gets into the circulatory system, albumin is what keeps it inside of the blood so that it doesn't leak into the tissues. And if we're not having synthesis of albumin, we have low albumin levels, then we don't have enough albumin to keep the water in or the fluid in the vascular system. So it's going to leak out and it's going to third space into the abdomen. So here I've included a chart on how portal hypertension can lead to these different things. So we already talked about how it can lead to ascites. And then it could also lead to things like hemorrhoids and the esophageal varices and all these other different things. So it's a good chart to look at. And then the second picture, believe it or not, it is not a pregnant woman. This is someone with some pretty bad ascites. And one of the ways the doctor tells is if you hit the abdomen a certain way, well, I should say percuss, not hit. If you percuss the abdomen a certain way, it gives this wave where you can see the fluid just rippling in the abdomen. So another complication of liver disease is, let me switch the slide so you can see what I'm seeing. Okay, is the hepatic encephalopathy. It's the neuropsychiatric manifestation of hepatic failure. It is life-threatening, and it results from the inability of the liver to detoxify the toxic byproducts of metabolism, with ammonia being a major etiologic factor. So ammonia normally is converted in the liver to urea, and with liver dysfunction, this can't happen, so the ammonia is going to stay in systemic circulation. Then it crosses the blood-brain barrier, and then it results in these manifestations. The manifestations are sleep disturbance, lethargy, and coma. And then they might have fetor hepaticus, which is, again, that sweet-smelling kind of fecal smell to the breath. With hepatic cirrhosis, it is a chronic progressive disease of the liver characterized by that replacement of normal normal liver tissue with diffuse fibrosis. And then what happens, again, is the damaged liver cells attempt to regenerate, but it's a very disorganized process. You get the abnormal creation of collateral blood vessels, and then the new fibrous connective tissue gets in the way of the liver's normal structure and it stops blood flow. So then you have the result of not enough nutrition or oxygen getting to the liver. So basically the liver thinks it's doing a good job at fixing the problem, but the compensatory mechanism actually does more harm than good. Causes of cirrhosis: alcohol consumption is the #1 cause. And then chronic viral hepatitis, chronic obstruction of the bile ducts, nutritional deficiencies with reduced protein intake, and then there's certain genetic diseases such as Wilson disease. That one I had to look up, I had never heard of, and if you were wondering, it's a genetic disease that causes too much copper to accumulate in your organs, with your liver being one of those organs. And then there's hemochromatosis, which is having too much iron. And there's different storage diseases, autoimmune hepatitis, so there are a lot of different genetic diseases that can contribute. And then for your statistic, more than 31,000 people in the U.S. die each year from cirrhosis. For your risk factor, men are twice as likely to have cirrhosis than women. With that said, interestingly enough, women are more likely to develop alcohol-induced liver disease, and they aren't really sure why this happens. Another risk factor, again, is your excessive alcohol. So the severity of alcohol-induced liver damage does depend on a couple things. One of them is the amount of alcohol consumed. Right? That's why it's important to keep to your moderate drinking. And then the number of years of alcohol consumption. So having a couple crazy college years doesn't necessarily doom your liver. It's years and years and years of use. And then other factors that play into it is immunity, your genetic and biochemical makeup, overall nutrition, diet, and health status. Some other things that are risk factors is IV drug use, hepatitis B, C, or D, biliary obstruction, exposure to certain chemicals like carbon tetrachloride, and then arsenic, phosphorus, and whatever chlorinated naphthalene is. And if you have infectious schistosomiasis. And that is actually a parasite that lives in freshwater snails. So that is more reason why I do not swim in freshwater. And this is just a more detailed slide on the effects of alcohol and how it leads to liver damage. It does have a direct hepatotoxic effect. Excessive intake leads to that fat accumulation in the liver cells. And then with continued use, you start to develop scar tissue. So that's just that slide in a nutshell. The onset of liver disease is usually insidious. You start to see some early manifestations, GI disturbances being one of them, and again, it is because of that alteration in metabolism of carb, fat, and protein. You can see anorexia, dyspepsia, flatulence, nausea and vomiting, change in bowel habits, dull, achy upper right quadrant pain, weight loss, and weakness. You might also see diarrhea or constipation. Some later manifestations include jaundice, bleeding due to that decreased production of hepatic clotting factor because of that inability to synthesize vitamin K, an enlarged spleen from backup of blood from the portal vein. Having an enlarged spleen can lead to things like thrombocytopenia, leukopenia, and anemia. And then you'll see skin lesions, which I have got a slide for next. You'll see peripheral neuropathies, and those come from deficiencies in thiamine, folic acid, and B12. The neuropathies are extremely common in alcoholic cirrhosis. And then anemia, endocrine issues, which we'll talk about, and then cachexia. So more on skin lesions. They come from the increased circulating estrogen because the liver cannot metabolize steroid hormones like it should. So you'll see two things. You'll see spider angiomas, which are these small dilated blood vessels. They've got a bright red center and then these spider-like branches. You can find them on the nose, cheeks, upper trunk, neck, and shoulders. And then palmar erythema, which is the red area on the palm. It does blanch with pressure. And then here you see pictures of both of those things. The endocrine issues. Sorry about that. My cat must have hit my carbon monoxide detector. Anyway, the endocrine issues you see because the liver, again, cannot metabolize the steroid hormones and other hormones that they're supposed to. So you'll see hyperaldosteronism. So this is going to lead to even more sodium and water retention as well as potassium loss. And then in men, you might see gynecomastia, loss of axillary and pubic hair, testicular atrophy and impotence, and then in females, they might have trouble with sterility and then abnormal bleeding in postmenopausal women. If a person with cirrhosis doesn't have any of the complications listed on here, they're said to have compensated cirrhosis, meaning that the body or the liver is doing all it can to compensate for its dysfunction, versus if they have any of these, they are said to have uncompensated cirrhosis. So there's the portal hypertension we talked about, and then esophageal and gastric varices. Varices develop in those areas where collateral circulation and systemic circulation communicate. They're super, super fragile. They have very little elastic tissue, so they are prone to bleeding. Esophageal varices are present in 30% of people with compensated cirrhosis, and it jumps all the way up to 60% in decompensated or uncompensated, They are prone to rupture. This rupture can cause potentially fatal hemorrhage. I mentioned this in chronic, but I'll mention it again. The first bleed episode does carry a 10 to 30% mortality rate. And then if you survive that first episode, there's a 70% chance of it happening again. And with that, it carries a 30 to 50% chance of death from the reoccurrence. And then gastric varices, they're not as common, but they are just as serious. The next one is peripheral edema from the fluid, and then ascites, hepatic encephalopathy, which we'll talk more about, or actually we did talk about already. And then the last one is hepatorenal syndrome, and that's considered a functional renal failure. So what that means is the kidneys don't have any structural damage. The problem is from the liver. You'll see oliguria, ascites, and azotemia, which is high levels of nitrogen in the blood. And the treatment for this, ultimately, is going to be liver transplant. You fix the liver and the kidney problems will go away. So, how do we diagnose? Diagnostic tests. It's a super vague slide, so I'm going to give you more details. So, of course, they're going to do the liver function studies to look at the function of the liver. If they are elevated, then that is what's going to indicate liver failure. They'll look at a CBC to see if there's any anemia. They'll look at coagulation studies. They would expect elevated values because there is that decreased production of clotting factors, so they're more prone to bleeding. They'll look at serum electrolytes. Hyponatremia is very common because of hemodilution. And then you'll also see hypokalemia, hypophosphatemia, and low magnesium levels. Bilirubin is going to be elevated. Ammonia levels will be elevated as the liver fails to convert ammonia. They might also throw in an abdominal ultrasound to look at the size of the liver and look at ascites. And then EGD they'll do to look at and treat the esophageal varices. And a biopsy is not always necessary, but it can help looking at cancer and then looking at is it cirrhosis or some other cause of the liver disease. And these next slides are just a little more in depth of some of the complications and their etiology and the manifestations. So I would definitely use these as a study tool. But we went over esophageal varices already. And then we talked about ascites. Let me see the next one. We talked about hepatorenal failure. We did not talk about hepatopulmonary syndrome. That is also common with cirrhosis, and you have atrial hypoxemia because of intrapulmonary vasodilation. So you might see some dyspnea, clubbing, hypoxemia. I mean, really, the liver does so much that when it has decreased function, it's pretty much affecting all of the body systems. There's portal pulmonary syndrome, which is a serious complication of portal hypertension. And then we talked about jaundice and cholestasis. All right, and then I also have here I actually don't know what this link is. Let's open it. I stole this link from Fern, I'm not going to lie. Let's see. Okay, yeah, it's a video on cirrhosis, so it's another good way to get a nice patho review. And that is all I have for you. Have fun studying and preparing for your finals, and do not hesitate to send me an email if there's something you're not sure of or something you don't understand.